Hello, good afternoon, everyone. Hello. Hello, we're going to get started in a second, so if you can find a table and we'll get started. And on behalf of the Novartis Foundation and IntraHealth International, this is my pleasure to welcome you today to that great side event, a long-awaited side event on non-communicable disease. As we gather here, we recognize the urgent need to address the burden of cardiovascular disease. Cardiovascular disease is a leading cause of death, and it's claiming close to 18 million deaths every year. For too long, addressing cardiovascular disease was thought to be too big of a challenge. And yet, the CARDIO4Cities, my God, the CARDIO4Cities initiative has proved otherwise. Its impressive results are paving the way for a sustainable, improved cardiovascular health across the world, one city at a time. Together, we can take the challenge of addressing cardiovascular disease in large urban centers. We have a proven framework. We have the tools to embark on this exciting journey, and we will do that together for better health equity. Thank you very much.
Thank you so much. And Philippe, did you present yourself? This is my partner in crime, Philippe Guinot, the Chief Technical Officer of IntraHealth International. And I am Aerts, the head of the Novartis Foundation. And it's my true pleasure to welcome you here all today. I'm really happy to see a full room. Thank you for coming, because this is going to be an exciting event. We will not only celebrate the successes of CARDIO4Cities, this cardiovascular population health approach we have pioneered successfully, and that we will hear from many of the panelists, but we will also launch a new organization, the CARDIO4Cities Accelerator. And the reason why we launched this new organization is because, as you hear from Philippe, cardiovascular disease is still the leading cause of death and disability in the world. The second reason is we know perfectly well what we have to do for cardiovascular disease. All the evidence is there. If there is one area in medicine that made such an advance in the last decennia, it is cardiovascular disease. So we have all the elements. We know what to do, but no one can really translate that evidence into action that has a real-world impact on people's life. And lastly, the reason is sadly that there is simply no or very little funding for cardiovascular disease for countries that still need support to address it. Because all the overseas development aid, or 98% of it, goes to infectious disease and mother and child health issues. So all of these reasons together is the foundation, in fact, behind the fact that we launched this new accelerator to be able to replicate CARDIO4Cities globally and make an impact on many more millions of people's lives than we already do. So tonight, we will start with a fantastic opening keynote from Honorable State Minister Awa Coll Seck, who is State Minister to the President of Senegal, who will give us the urgency of addressing cardiovascular disease in Africa and globally. We cannot neglect that anymore. We have to act now and act differently, that it works. Then we will hear from Professor Avezum from Brazil, how the CARDIO4Cities approach works, what it is in fact, but also what its results were and its real impact in Brazil and in the other cities where we pioneered it. And lastly, we will have this very interactive panel discussion with all these esteemed panelists here you see around us. And we hope that this is going to be very interactive, because our panelists will discuss between each other, but also with you, and hopefully with many questions from the audience to make this a very interactive event. And then we end with the official launch of the CARDIO4Cities Accelerator. But now let me introduce to the most important person of the night, who is our moderator, Shiulie Ghosh, who's an international broadcaster, journalist, and moderator, and who will guide us through the evening. So Shiulie, thank you, and the floor is yours.
Thank you very much indeed, Anne. I don't think I've ever had such a nice introduction. Thank you. And I trust that you can all hear me clearly because I am wearing the world's biggest microphone. Yes, good. Your Excellencies, ladies and gentlemen, thank you very much indeed for joining us for this very important launch of a global partnership to improve cardiovascular population health and equity. I would like to extend a very warm welcome to our honoured guests who are here with us today from the governments of Malaysia, Saudi Arabia, Qatar, Portugal, Togo and Senegal. Very glad to have you with us, and we are especially pleased that we're going to have the opportunity to hear from the Honourable Minister from Senegal. Thank you very much indeed for being with us. I'm not going to repeat what Anne and Philippe have already said about the urgent need to tackle cardiovascular disease. We know it's one of the critical issues of our time, but what we are going to talk to you about is the success of the CARDIO4Cities initiative, which demonstrates how cities can significantly improve heart health at population level by working across different sectors in multi-sectoral partnerships using real-time data to drive effective interventions. The CARDIO4Cities approach has been pioneered and validated across 3 cities in 3 continents, and the results are unambiguous. Hypertension control increased by at least 3 times, up to 13% of strokes, 12% of coronary events averted. Just imagine what the health of a population could look like if those results were to be continued. So our key speakers will explain how CARDIO4Cities approach can make a huge yet cost-effective difference in urban settings. It's simple, it's comprehensive, it's effective, and it's scalable. And then, as Anne has said, I will have the pleasure of guiding our team of experts. They're on either side. I will introduce you guys all when the time comes, but they are going to be examining some of the key factors for success. That is the importance of multisectoral partnerships, the need for data, how the model can be replicated and expanded, and why stakeholders should be investing in this model. And we do want to have questions from the audience. We want as many questions as possible because we are all really keen to answer all your queries, and we would especially welcome any questions from honoured government representatives who are here today, because this might be an approach that you want to implement as well. To start proceedings, I am now delighted to introduce our first speaker. Now, she is someone who has been involved in CARDIO4Cities right from the start. She has backed it every step of the way, and she is in a unique position to talk about the need to invest in cardiovascular population health in Africa and globally. Please welcome Her Excellency Awa Marie Coll Seck, Minister of State to the President of the Republic of Senegal.
Thank you, Madam Moderator. I would like to thank all the organizers. I know Novartis Foundation, but also IntraHealth, and thank you for inviting me. But more, I would like to congratulate you for the initiatives, because I will see, and everybody will see later, that we have something we can really work on to save lives in Africa, but also in the world. And I would like really to tell you that I am very honored to be here. As you said, cardiovascular disease, I think that this is something really everybody now, if we didn't know it, but you have said it in your speeches already. And I think that it is very clear that it is really a burning issue of our time, and we need to do something. We need to do something. We often are saying now that cardiovascular diseases or all the non-communicable diseases are more and more important, particularly in our world, but we need to do something. We cannot just decide that it is important, it is a problem, and after, don't change the way we are working. It's a leading cause of death and disability, and you have said that already. We have 18 million deaths a year, and this is really a problem. When we look at a lot of our diseases, we think they are the most difficult and they are impacting a lot in our population. And we look at the numbers, it is really that we need to do something for cardiovascular diseases. And this need to be really addressed, and we need to change the way we are working on that. What is also important, we have a lot of evidence showing that we can do it. When we look at scientific results, we see that today we know what are the determinants, we know that we have some medication we can use, we know also what are the complications. All this is scientifically clear. Why we are waiting again? Why we are waiting? We know also that when we have scientific evidence that somewhere today the problem is not just a problem of the north. Because before, everybody was saying we have non-communicable disease, but also cardiovascular diseases. They are more in the north, and maybe it's an issue of people from Europe, the US, etc. But what we know is that more and more, it is a burning issue also in our country, and particularly in Africa. We have the double burden. Still, the other diseases, HIV, TB, malaria, we have done we have some good results, but we know that with a lot of other things, this can come back. I look at malaria, where now you look at the high-level towns in Ethiopia, where they never have malaria. With climate change and all this, they have it now. Now, it's just to say that the infectious disease will be there and will stay. We will do things, we will work on that, but they will be there. But at the same time, we have increased numbers of people having cardiovascular disease and non-communicable disease also. How many people have in their family diabetes or stroke or cardiovascular disease in general? And this is not something we just tell you like this. It is something you have in your own family. And when you, with a disease, when you have seen the disease very close to you, this is that it is a problem, because somewhere it has been everywhere, and only when you look at it and you have it in your family, you think that it is important. And we need to look at it, and I think that this will be very important. Another thing is that the money, the financial support. We have a lot of support needed if we want to look at diseases like cardiovascular. And you have said that also already, that we, the ODA, we are showing when we analyze it that it is less than 2% for non-communicable diseases. And I am not saying for cardiovascular. It's just to say that this is an issue. But more, the issue also is in our own countries. We are not prioritizing the non-communicable disease. More and more, it is on our agenda, but it has not been on the agenda for too long. And today, we see that we need more financing also to be able to tackle it. It is why I am very happy to say that we have now really, we have to join our forces. We need to, I think that, okay, we need to join our forces and to ensure that together we can do more and we can do better. And when I say together, it's not only between medical people, medical doctors, but we need to have a multisectorial approach, a pluridisciplinary approach, but also to ensure that we have people from the government, people from the private sector, people from the community. And I would like now to give the example of Senegal and congratulate really the authorities, and particularly the leadership of the Ministry of Health. And also I have seen that we have our head of division of non-communicable diseases with us, and she will be able to give you more details. She is working on that on the day-to-day, and I think that she deserves to explain to people what we are doing in Senegal. But just to say that when you put together, as I say, private sector government, but also NGOs, academia, everybody involved, we have results. And what we have seen in CARDIO4Cities is that in Brazil, I know that Brazil also will give us some very clear information on what happened there. But in Senegal, you have been happy to see that in 1.5 to 2 years, in Brazil, they have tripled at least the control of blood pressure. And this is very important to show that it is not only in Brazil, it is also in Africa, it can be also in Asia. This is important because often when you look at something in Brazil, you say, oh, this is Brazil, they can do that, but not us. But with all the examples we will have today on the table, it will be clear that if it is done somewhere, it can be done elsewhere. And in Senegal, we have also an increase on blood pressure control to close to 40% just in months or less than 2 years. And this is really, for me, a big achievement. And I would like to, as I say, to congratulate all those the partners who are with us and all those who are involved really on this achievement. Now we can say that Senegal is also an example for us, and it has brought this initiative to life. Now we had before some ideas that this will work. Now we have seen that it is working. Now our problem is more to go to scale. To go to scale in a country, but also go to scale for us on all the continent. And I would like to say that, and I'm sure that the Ministry of Health and all the partners in Senegal will be happy with me, because it is an issue that have involved authorities, but all the health system managers, the health providers, the community health workers, and the community in general. Everybody was there. Now we need only to use and give to all the world the tools we have used, all the things we had with us, and share it with the world. We cannot keep it for us. We need to give it to all the countries. And I'm happy to see that we have here some government which are really coming to this meeting. And I would like at the end of this meeting to ensure that they have the possibility to be in contact and to develop it in their own country. I want to say that, to finish, we have only maybe 3 important things. You are not doing something too difficult, because we have learned from HIV, we have learned from COVID, we have learned that we need really to accelerate the detection. If nobody has his own blood pressure, how he can know that he has a problem? So this is the first step. The second is to standardize the management. All the practitioners, everybody needs to have something clear. As soon as I have this, I do like this, something simple. And if we can have it at country level, at an affordable price, also this is important, we will do it. And also engage the patients, because often we are working with patients like they don't understand anything. They are more intelligent than us, and they are ready to take their own health and do something. But we need to just put them to and work with them. If not, we will be always doing the same, coming, giving instruction, we need to work on determining, advocate with them. They need to be themselves part of the story. And with that, I am sure that we will be successful. I would like to thank you for your attention. I am looking forward to hear more the panelists. And Madam Moderator, I can tell you that I will be one of the best audience possible because I am here to learn, and I'm here to ensure that for me, all the people who are sharing with us their own experience will help all the others who are here and ready also in case to ask some questions. But we need only to join our forces, work together, and we will be successful. Thank you.
Thank you very much indeed, Your Excellency. I think we can all agree that a blood pressure control rate of close to 40% in Dakar is a very impressive achievement. So let's now hear a short overview of the CARDIO4Cities approach and its effect on population health. Our next speaker is someone who has spent a lot of time assessing the impact. So please welcome Álvaro Avezum, the Scientific Director of the State of Sao Paulo Cardiology Society.
Okay, good afternoon, everyone. I should thank Novartis and IntraHealth for this brilliant opportunity for me. And I'm going to present the results on behalf of our partners and everyone that actively worked in this project. And it is indeed my honor, my privilege to be here presenting the results. But there's a challenge because we've been working on this project for 5 years, and I'm supposed to present in 10 minutes using 8 slides. So, and you can see my younger brother that's a little bit different than I am today. But anyhow, so the CARDIO4Cities approach, I would start by the ending. Turned out to be a life-saving tool and not only an approach for treating patients with hypertension, and reassure that by treating hypertension, we were able to reduce stroke rates, at least by modeling, in 3 different areas representing 3 different continents. So we are here to present the results and see how this is simple, implementable. Certainly, we need to simplify, but as a cardiologist by training and also research, this was the first time that I was surprised to see that we could reduce even more cardiovascular disease mortality, treat important risk factors by having these collective efforts, and no doubt about that. We haven't thought before. This is innovation with simplicity, or we are simplifying the complexity. We are good for generating scientific evidence, but the implementation, we are far from the ideal. And this is the first step for proving that is implementable and also is replicable to different areas of the world and not only in Sao Paulo, Dakar, or other regions in the world. So you already know that we have cardiovascular disease as the leading cause of death in the world. So before the pandemic is about nearly 18 million deaths by cardiovascular disease. And when you see the main cause of death in the world, 1/3 they are caused by cardiovascular disease. But this is the overall picture. If you see low-income countries and middle-income countries, I can talk about the PURE study, it is a prospective cohort study, is about 40% of the cause of death in those low-income and middle-income countries are from cardiovascular disease. High-income countries, 1/4. And also, there is consequence in costs. And you know that the money is, most of the time, for health is short. And in Brazil, the cost for treating disease, to prevent and to treat those consequences of the disease and loss of productivity, is about $72 billion US. So a lot of money. So we have the scientific knowledge, and I'm sorry to remind all of us that hypertension is one important risk factor associated with acute myocardial infarction, is the most important factor associated with stroke. And from the PURE data, again, more than 200,000 people follow for at least 15 years. Hypertension turned out to be the most relevant risk factor associated with the combined MI, stroke, and hospitalization for heart failure. And not only cardiovascular event, but was the second most important risk factor associated with premature death. So why we have this scientific evidence and we don't apply in the clinical practice? So in terms of the gaps, we know, again, from the Pew study, that between 8 to 14% of the patients from low, middle, and high-income countries, they have blood pressure under control. So 1 in each 6. So hypertension is simple to detect, it's easy to treat, but even in high-income countries, this is a universal phenomenon. We are not discussing only low and middle-income countries. Even for high-income countries, it's still behind the reasonable rate of controlling hypertension. And as you say in the slides, we need a winning strategy that should be simple, implementable, and replicable. Nice words, but you need to test. You need to implement and see if you are able to do that. So this is a very busy but important slide that explains the CARDIO4Cities approach. So C stands for improved quality of care. We need to bear in mind that we have 3 dimensions here: detection of hypertension, treatment, and controlling. And also from these 3 dimensions, we have 3 components: population or individuals, health system, and health professional. All the time, we need to combine those 3 factors. And we did a situational analysis just to detect where we are, because the only way to improve, the only way to have more quality is by knowing what we are doing. We cannot assume that we are doing the best practice in terms of healthcare. We need to have metrics, we need to have a KPI, we need to have tangible outcomes in order to see what we are doing. So improving quality of care was the first one. Early access to healthcare, because sometimes patients or population, they don't have access. Reforming policies with proven benefit. If there is no proven benefit, we need to try to do some adaptation to local level. So in Brazil, for example, we had some regulation, we have policies, and the CARDIO4Cities was adding new information respecting what the health system were done there. So there is room for improvement, but this is not about replacement. The fourth one is absolutely necessary. We need to have data. So digital technology must be there. Otherwise, if you don't have data, you don't have information, don't have knowledge, how can you do any improvement? It's just impossible. I'm not supposed to discuss which one of those 6 is the most important, but I would vote for the 5th one, because this intersectorial collaboration is key. It's about coalition. It's about work together, collective effort. So this was key, and on the other hand, one of the most difficult, because we have common goals and different partners, and sometimes with different agendas. So how can you come up at the end to have, I would say, a very sensible agenda that preserve what there is there in the health system, but on the other hand, we could add some new information and try to implement the knowledge that we already have. And the legacy is fundamental for any country, for any city, because this program, it ensures the local ownership. So the program had been started, for example, in Sao Paulo, but it's there continuously being implemented in different cities in Brazil. We had 3 cities, 3 different continents, and especially, since I'm from Brazil, from Sao Paulo, the population of Sao Paulo city is 12 million, but the metropolitan area is about 21 million. And the prevalence, we thought, before having data, that the prevalence was 25 or 20%. Sometimes we just repeat what we heard, and when we started to collect the data, especially contemporary data, is almost 50%, the hypertension rate in Sao Paulo city. So it's extremely high. And if you have a higher prevalence, you can assume that the potential relevant is going to be higher, that we call the population attributable risk. If you prevent the risk factor or if you treat the risk factor, you can prevent the occurrence of cardiovascular events. So this is important to discuss the relevance. And as I said, cardiovascular disease mortality 30%, but recently we know that it's 42% in our region. So we were not expecting to see the results. So we had not low expectation, but real and maybe true expectation, because only in 15 months, sometimes is the time just for implementation, not to see results of implementation. And in 15 months, we could almost triple the blood pressure control. Believe me, this is new, and we don't see that even in high-income countries. If you have 1 in each 3 patients with hypertension being controlled, that's good. And we started with 12, that's real, and in 15 months went up to 31%. So we need to sustain and try to have 50% or even more. And there is some external consistency of the data, because if you see the car, if you see Ulaanbaatar, the same phenomenon, the same pattern of increasing of blood pressure control had been observed. And the program is one, but the adaptation to the local level is unique. So the adaptation, certainly the adaptation from those 3 areas, they are different. But that's the beauty of the program, because it's adaptable to the local environment. If someone, as cardiologists, say, well, you had almost tripled the blood pressure control, and were you able to see any benefit in hard outcomes, cardiovascular disease mortality, stroke, or MI? First of all, as a researcher, I would say, I'm not going to expect, because 15 months is a short period of time, to observe any benefit. So, without any pretension, we evaluated through modeling to see this blood pressure control improvement would reflect in benefit in cardiovascular events. And we were able to see in Sao Paulo, in the same short period of 15 months, a reduction in stroke hospitalization in that area. I should tell you, since the beginning, that this program had been, because we don't have enough time here, in primary care units. So this is a primary care approach. We started in a few primary care units, and this had been scaled up to different areas in Sao Paulo. So the hospitalization due to stroke had been reduced by 13%, and the cardiovascular disease events by 12% when you combine stroke and myocardial infarction. And again, external validity, the same phenomenon, but of course in a different proportion, had been observed in Ulaanbaatar in Mongolia and Dakar in Senegal. And another consequence is about efficiency. We know that resources are always limited. And in middle-income countries and the low-income countries, we need to find another word for limited. Certainly is more than limited. And the cost-effectiveness, there is the threshold, for example, in North America, that the quality is the quality-adjusted life years. Is around $40,000 US to be qualified. Lower than that to be qualified as cost-effective or economically attractive. And in Brazil, certainly is not $40,000 US, but I can reassure you that the quality for about $784 US is absolutely cost-effective. So we had blood pressure control, signal of reduction in hospitalization for stroke and cardiovascular disease events, and also cost effectiveness of the intervention. 2 more slides. It's not complicated, but we had a lot of actions that we use as approach that we call design thinking, and there is the co-creation, because sometimes as doctors or any research or health professional, we discuss what is the best for the population around the table without knowing their knowledge or lack of knowledge. And the co-creation means that we create potential solution for the situational analysis that we faced understanding their needs, their knowledge, and lack of knowledge. So these processes should be simplified in order to be replicated to different parts of Brazil, of Senegal, and other parts of the world. So the target continued the same: detection of hypertension, treatment of hypertension, and controlling hypertension. The action that should be defined: accelerate decision, should be efficient. Standard care is not easy to have a common by the guideline. And by the way, let me tell you, at the beginning, we had with our colleagues at the American Heart Association using the guidelines. And the guidelines from the American Heart Association had 196 pages, and the guideline from Brazil had 180 pages, and we just got this document, so we should implement that. Okay, can we implement that? And after almost to 8 weeks, we simplified by 8 pages in order to be implementable. Otherwise, it's just a document for consultation. For implementation, should not be long, should not be complex. We all know that. So, and it enables self-care, because the patient or the individual should be responsible for his own health. So we are not just providing, we are asking them to be responsible for the care. And finally, we need to have data. Digital technology is key. Partners through a coalition, an efficient coalition, and health technology is always welcome. And it certainly will improve this approach or life-saving tool all the time according to the new information or the new technology related to health. And my final slide is the conclusion that certainly there are other factors during the discussion we can address along our colleagues, but the key success factor, the fourth thing is it should be or it must be 100% aligned with local priorities, with the health system in the country. We cannot create a parallel approach. And driven by local authorities. If you don't have endorsements of government, of medical societies and other partners, we won't succeed. Secondly, strategic partners. If you have a common goal, a common agenda, it's a little bit easier to have strategic partners. Baseline assessment, if you don't have metrics before implementation and metrics again, we're not able to say anything about the program. We should do that. Co-creation of strategies or potential solution locally. What we identified in Sao Paulo sometimes cannot be used in Rio de Janeiro, another Brazilian city. So adaptation to the local level is not only for the national level, but across the country. And the focus on patient health, the triad, patient, health system, and health professional. And the take-home message, of course, I'm not going to say this is that period, but it's open for discussion. This model is ready for replication. And why I'm telling you that? We live in Brazil, and it is a complex country, okay? And Sao Paulo city is a cosmopolitan city, but it is a complex city. If you can do in a complex city, certainly is replicable to other Brazilian regions. That's why we conclude that. And we would like to open for discussion that is easily expandable for other regions of the world and not only for hypertension. We started with hypertension, but we have diabetes, we have cholesterol, we have obesity, physical activity, mental health. So it's open for any risk factors that you have a good, solid, and robust evidence behind to use the strategy by the CARDIO4Cities strategy or accelerator. Thank you very much for your attention, and I'm sure that we are going to have a very vibrant discussion after that. Thank you.
Thank you very much, and I know we'll have a vibrant discussion because Álvaro is also on the panel and will be ready to take your questions. So without further ado, I'm going to introduce all our speakers one by one. I'm going to start on my right. This panel, this group, is going to discuss in particular the importance of multisectoral partnerships to improve cardiovascular population health. At the far end, we have Seynabou Mbao, the head of the NCD Division Ministry of Health in Senegal. Welcome. Next to her, we have Professor Srinath Reddy, past president and honorary distinguished professor at the Public Health Foundation of India. Next to him, Dr. Rifat Atun, the head of the Harvard Health Systems Innovation Lab. Great to have you with us. And Melanie Turner, International Science Program Director of the American Heart Association. We were going to have Alain Lebrique from the WHO. Unfortunately, he's been unavoidably detained. To my left, to talk about the case for investing in cardiovascular population health. So they're going to be talking money. We have Thais Junqueira, head of the Amani Foundation in Brazil. This is a non-profit which supports civil projects for disease prevention. Next to her, we have Patrick Elmer, founder and CEO of iGravity, an advisory firm which specializes in impact investing and innovative financing for development. Then we have Hassab Ahmad, the president of Europe, Novartis Innovative Medicines. Dr. Bill Weeks, head of Microsoft AI for Health, and of course, Álvaro Avezum, the scientific director for the state of Sao Paulo Cardiology Society. Great to have all of you with us. Right, I'm going to come straight to you, Srinath, because I know that you are a passionate advocate for cardiovascular disease prevention, and your country, India, growing population. I think it's going to become the most populous country on earth. Cardiovascular disease, a huge problem there. What was going through your head when you were listening to the CARDIO4Cities initiative being explained? Is that an approach you think could have an impact in India's cities?
Well, we have already become the world's largest population. And we have a huge problem of a relatively young country with young demographic profile, but with a very high burden of cardiovascular disease. About 30% of all deaths are due to cardiovascular disease. But a considerable amount of those deaths occur very much in the productive middle-aged years. In fact, in the age group of 30 to 70, you find majority of the cardiovascular disease deaths occurring. And even if you survive, there's a huge amount of residual disability because of stroke or heart attacks and heart failure. So the demographic advantage that we were hoping to have of a young population will be dissipated if we do not ensure healthy life expectancy. And hypertension is widely prevalent in urban areas. It's also there in rural areas. But with increasing urbanization, we have a challenge now in terms of controlling cardiovascular risk and ensuring a disability-free, healthy life expectancy. And therefore, it is important for us to have the kind of program that's been outlined, which can have a population-wide reach as well as impact. And
a population-wide reach with impact, so it needs to be comprehensive, but it also needs to be simple, and I guess the important thing is it's also got to be cost-effective.
Yes, absolutely, but I think the key lessons that came from this particular project is there are two main ingredients. One is people-partnered public health with the active community engagement, and second is digitally enabled, data-driven, decentralized decision-making for delivery of services.
Lots of D's in there. Well, let's talk about data. Let me come to you, Rifat. I know that the Health Systems Innovation Lab, so this is a global training and research lab. You've been partnering with Novartis Foundation in a data collaborative. Now, the point of that is to find out what exactly is important when it comes to high-impact health systems. When it comes to population health and cardiovascular health, what factors are important? What needs to be there for a good, effective health system?
Well, thank you. Before answering that question, it's very important to really understand the nature of the problem and the magnitude of the problem. Because what we heard from in Senegal and also in Brazil, this is across all countries. We've been doing a number of studies using individual level data within national representative data. And the control levels for hypertension and diabetes are less than 30%.
Wow.
Actually around 25% in Latin America, which is one of the higher performing world regions, and less than 10% in sub-Saharan African context. And this is not just in low and middle income countries. We extended our study to high income countries. In fact, last year we launched the report looking at management of cardiovascular disease in the G20 countries. And I have 2 of my team members who were involved in this study. And what was very surprising to us was that, and again working with colleagues from OECD, how little data there were to really understand health system performance. So on the one hand, we had a massive problem. We have evidence, but on the other hand, we really don't know what the health systems are doing. So to try and answer your question, what works, very difficult to tell. Now, we have evidence in terms of individual level interventions, but at systems level, it's very difficult to draw on the data to say what works.
Why is this data not available?
Yeah, it's shocking. Well, you tell me. It's very surprising. I think we've been very complacent. We've been very complacent. And also, I would say that we need more activists working in the space of cardiovascular disease. I saw my good friend Peter Piot. When I was working at the Global Fund for HIV/AIDS and AIDS, tuberculosis, and malaria, AIDS activists were real activists. They really wanted results. Having 2% of ODA going to cardiovascular disease is just not acceptable. But what is important, what we're doing with the data collaborators is bringing together all the data sets that are currently available as granular data as possible to really analyze across all countries around the world what are the factors that influence access, detection, treatment, and control. And we have to rethink about the risk at the individual level because we've defined it using physiological parameters. But one very important determinant of outcomes is actually wide inequalities in relation to access.
I was going to say, because if you don't have the data, you don't know where the gaps are. And that's vitally important.
But there are huge inequalities. Social determinants we need to better understand. We need to get new insights onto what drives difficulties in access to health systems and why the health systems are underperforming. So in our next meeting in a year's time, I'll be able to give you more precise answers.
Excellent, hopefully. Good to hear. Excellent, thank you, Rifat. Seynabou, let me come to you. We've been hearing from the Honourable Minister from Senegal about the importance of public-private partnerships to address cardiovascular diseases in simple and cost-effective ways. Can I ask you, as head of the NCD division at the Ministry of Health, what is your experience with multi-sectoral partnership approach in Senegal?
Thank you for giving me the opportunity to share the Senegalese experience in implementing the CARDIO initiative. So first, I would like to thank the Ministry, Professor Coll Seck, for this excellent contribution. Senegal has committed to the fight against NCDs by developing a first plan integrated from 2017 to 2020, in which multisectoral collaboration is one of the key strategic axes. Thus, a multisectoral committee was set up in September 2019 by ministerial order to promote and coordinate the intervention of the whole development sector, national institutions, civil society, the private sector, and development partners. The committee has developed a roadmap, and the first actions of which were carried out with the education sector, with the integration of NCDs and risk factors in the basic education program in elementary school. So with CARDIO, CARDIO is an innovative approach that puts urban health at the forefront. In Senegal, health is a competence that has been transferred to the local authorities. And this initiative has reinforced the decentralization of the management of cardiovascular disease. However, it's important to advocate to all stakeholders for greater involvement in the fight against NCDs and ownership of the roadmap with the provision and funds to support the health sector.
Had a very positive impact.
Yes.
Thank you, Zainabu. Melanie, let me come to you. I know that the American Heart Association was the global data partner for the Novartis Foundation during the validation phase of CARDIO4Cities. So this is information on progress, on outcomes. Why was that so essential to its success?
At an extremely high level, we think you can't change anything if you're not measuring it. So that's the big answer. Thinking about the program specifically, across the 3 sites, very different, it was going to take that shared measurement and that agreement on what everyone was going to be looking at in terms of endpoints to really monitor the program in terms of administration, planning, resource allocation. But also, to the point earlier about the massive breadth of evidence in the guidelines, really using that data to be able to bring that guideline down to the local level, what's important to that particular site, what's going to work, where the gaps are, and how the program could adjust along the way to really be effective in terms of what that particular local environment needed.
Philippe and Anne were saying right at the beginning, you need the data to drive effective interventions. Can you give us an example of how data was used to change something or implement something?
Absolutely. And thinking about just the multisectoral aspect of this program, which is so amazing, and was really the turning point of what made the success happen in every place. In Sao Paulo, for example, and the prevalence difference that Dr. Avezum was mentioning earlier, that was a good example of where we found that the prevalence wasn't as high coming into the clinics. So knowing that hypertension is a silent disease, there are many people out in the population who it's undetected. They were unaware.
Wow.
So a community effort at the football stadium, screening for hypertension, as he mentioned, was very simple to do, very quick, was able to identify more people to bring into the clinic.
What about monitoring and follow-up?
Monitoring, follow-up, great question. And to the multisectoral aspect of this, making the program more horizontal instead of just in the clinical in a vertical sense, being more horizontal, bringing the pharmacist in. They're the people who are distributing the medications. Adherence is a massive issue for hypertension, just because we're humans and sometimes we don't do the thing that we know we're supposed to do in taking our medications every day.
We don't feel the effects of high blood pressure, so it doesn't seem to be so urgent that we carry on with a regime, but of course it is.
So yes, so those pharmacists are the ones who can monitor the distribution, and if someone is slacking, if they're only showing up, getting their prescriptions every so and again.
Off from the pharmacist.
Yes. So bringing that piece into the program was really influential in education for the patient themselves and reporting back to the clinic on the follow-up.
One last quick question. Did you find different data across different cities? Were you surprised by any?
Absolutely. And I think that's part of the power behind this program is really every city's very different, and having this intervention and being able to tailor it, it's really addressing that equity issue around health and being able to tailor something, hypertension, management and control. We have the guidelines for that, but how we adjust for what a community needs is the power of the program.
Yeah, it just seems extraordinary that we from everything you've all said, data is obviously key to a very effective intervention. For the moment, thank you very much indeed. Let me go over to the speakers who are going to put the case for investing into cardiovascular population health. I'm going to start with you, Hassie, because I read a really interesting article about you. You wrote it, and you said, let me quote, "If we want to live up to our ambition of reimagining medicine, we must first think differently." Well, cardiovascular disease, leading cause of death and disability in Europe and in other countries. What do we need to think differently about? What should we be doing that we're not doing?
I think it's been mentioned already today that this is not about finding new evidence much of what's needed we already know. This is really about asking the question, what's it going to take to put evidence into practice? And when I say we need to think differently, the we is quite a broad church of we, and I think it really starts with political will. So there's a real absence of political will when it comes to really addressing cardiovascular disease at scale. You know, we've heard some of the numbers today, 18 million people, so that's quite an intangible number, but that's 50,000 people a day. That's a large football stadium worth of people a day, 100 jumbo jets a day falling out of the sky. And 77% of those are preventable. So we need to make the case for investment. You know, the cost associated with cardiovascular disease, we know, was mentioned earlier, even in developed countries, 2/3 of cardiovascular events, including death, are of people of working age. So there's a huge productivity loss, a lack of tax revenue. So it's really going to require government, academia, and industry to really come together to reimagine what's it going to take to reduce cardiovascular risk and ultimately reduce cardiovascular events. If we don't do that, we will not meet the UN goal of reducing non-communicable diseases, preventable non-communicable deaths by 1/3 in the next 10 years or so.
You pose the question about political will and why there's a lack of investment. I guess the obvious answer is that there are so many things to invest in. There are so many competing priorities. How does the private sector help with that in partnering with health authorities and governments?
There's a couple of things that we do. One is actually who we're engaging with. So as an industry, we've typically just engage with health ministries and healthcare sector leaders within government. But increasingly, we're seeing now the opportunity to work with Treasury, with finance ministries, Ministry of Innovation, to make sure that when a government response comes out to cardiovascular disease, it isn't de facto a health ministry response. So one is engaging with a broader level of people, but also using much of the competence we have in demonstrating the value of medicines to demonstrating the value of actually treatment approaches like this. So demonstrating the cost per quality for taking on a particular treatment approach. That's something that we can work with governments and healthcare systems to actually bring many of those competencies in other parts of the value chain, the health delivery value chain.
Brilliant. Thank you for that. Let's talk AI for health, Bill. Now, I know that your AI research across communities in the US identified the impact on health by non-health factors. I find this totally fascinating. Socioeconomic determinants, where you were born, where you grew up, where you go to school, where you work. All of those things can impact on health. Why is it important to understand that when we're looking at cardiovascular health at population level?
To understand that, because it's not right that geography is destiny. That's not fair. If you're born into a wealthy place and live there, that shouldn't define your entire life. And it's, in effect, inequitable, right? And we want to improve equity in the world, hopefully. And so I think by understanding what are the factors that can be modified, that can address those inequities, that can lead for the greater population to have access to better health care and better health, we all win. We pay less for health care when that happens, so we have more disposable income, all of us. We were talking earlier, people who don't die are actually able to consume more, and they're able to work more and pay more taxes, which is a good thing for the world. And people can have much richer and more beneficial lives and contribute to society much more effectively if we address these things. So it's critical to understand those things and fundamentally to be able to understand them in a way that we can identify the modifiable ones and address them.
Because, I mean, you talk as an economist as well as a physician. So bring it down to the nuts and bolts for us. There's an economic case for investing in population health, isn't there? We're right to say that a healthy population is more productive, more economically active?
Yeah, absolutely. I mean, if you know, there's absenteeism, there's presenteeism, there's all these problems associated with health. And I'm actually a psychiatrist by training and mental health as well, right?
So is there anything you don't do?
So I think so there's a clear economic advantage to doing this. And just as people have brought up earlier, I think you treat this early, you avoid hospitalizations, you avoid MIs that are expensive, you avoid disability payments, disabilities for the people, which is a horrible thing, disability payments by governments, which is expensive, and again, takes from discretionary income. slows the economy. So all of these things, I think, combine to suggest that there's a great return on investment to not only the economics, but also to the health of the population. And we need to get really good at being able to identify and capture and articulate those changes.
Bill, thank you. Thank you very much indeed. Thijs, let me come to you. Your foundation, Umani, has worked very closely with CARDIO4Cities, the CARDIO4Cities initiative, in Sao Paulo for many years, and Umani is now funding the first replications of its approach in other cities in Brazil, which is great news. Just explain for all of us why you're so convinced that investing in CARDIO4Cities is the right thing to do.
Well, first we started supporting and investing in the program since 2018, when the program started to be implemented by the Novartis Foundation in Sao Paulo. And we are in a country that is huge, is very diverse and very unequal as well, and with a great influence of the social determinants. The only way we find to tackle NCDs and our taxes, like you see in the other parts of the world, we really need to take care of it and to do something. The only way we saw to do this is through simple methods. We believe that health policies and health policy that works, they are on a country level. But the solutions, they need to be regional in Brazil, and they need to be local as well, because all of these influences. And after that, we started working with patient records. We tested, we evaluated, we pilot a simple method. We believe that now it's time to really expand and to really pick what worked in a really complex setting, as Dr. Álvaro said, in Sao Paulo, and to bring this to other regions with the adaptations and to shape something that really worked for the regional and for the local authorities and the community as well.
So Álvaro was explaining how complicated and complex Sao Paulo is. Can I ask you, what differences have you seen when it comes to CV services? How have you seen the difference in Sao Paulo since CARDIO4Cities initiative was based there?
Well, there are two things that really comes to my mind when you talk about the complexities of Sao Paulo and also the opportunities. First, we had a big challenge in the beginning of this project regarding data and regarding availability of connectivity and data available in the health units. Sao Paulo is a big city, but sometimes this wasn't there. So the evaluation partners, they did a terrific job in terms of collecting what was available, making this in a more electronic format, and also finding creative ways to assess impact. This was very important. And we believe that in a really big city, this would be all in place, but it wasn't the case there. In Brazil, we still have a long way to go until we have this more organized in the country. So we had to work with this. The other thing that was very remarkable in this initiative was about the community involvement, and community involvement in a really micro level. This made all the difference. If you talk about implementing this in a city with 10 million inhabitants, you would never think about having the local schools, the local social assistant equipments, the local cultural equipments. They were all involved in making people aware of that importance. As mentioned, we're talking about a silent disease, and you need to mobilize people to go to the health unit and to discover something that sometimes they didn't really know that they had. We saw in Sao Paulo some men about 50, 55 years old that they have never measured their blood pressure before in their lives. This is what we found when we started implementing. So this community mobilization was key. And if you could do this work in Sao Paulo, we can do this everywhere else, we believe.
And you're right, because awareness is the first step towards prevention, right? Even just getting people to measure their blood pressure on a daily basis. Thijs, thank you very much indeed. Patrick, can I come to you? So your firm, iGravity, promotes impact investments in enterprises which have measurable positive outcomes for society. I think that's fascinating. What do your investors look for then when it comes to areas of health and social need, particularly in emerging markets?
Yeah, we heard all the evening that there is enough evidence, but resources are limited. So obviously the question is, how can we engage the financial community, and to what extent to mobilize this funding? Now, impact investment is an emerging approach which is growing rapidly. It's about $1 trillion in size today, but it's still very small compared to all the money that we have in the financial market, so it's less than 1%. Now, impact investors, it's not a monolithic block, it's a very diverse group of actors, but before anything, these are investors. So they're looking to deploy their money, their capital, and they want their money back. As all of us, we all have saving, we invest. Even when we want to generate impact, we want our money back. So I think we should never forget that.
Well, not just our money back, but a profit.
Exactly. That's the next question. How much profit you want to take home? And are you willing to sacrifice some of the profits for more return? And some investors are not willing to compromise on financial return. So especially, banks and family offices, wealth manager, even pension funds, our pensions, even when they do impact investing, they want to have competitive financial return. So they can only invest in certain types of investments that allow them to bring home what they want. But then on the other hand, there is also a large group of very interesting investors which are more motivated by the impact side and actually willing to get back less than for traditional investments. I would also differentiate between sophisticated and non-sophisticated impact investors. Sophisticated ones would understand the complexity and advocate for the partnership models we have been discussing. The non-sophisticated ones, they would be more like tick the box, is my investment compliant, sustainable compliant, impact compliant. But then maybe to close the circle with the discussion, the ultimate question for impact investors is how do they generate the financial returns and how do they get the money back? So they invest into something, into an organization, an enterprise, a fund, a project. They want the money back either because that entity receiving the money has the ability to pay back a few years later, or because you have possibly an outcome funder, an organization that is willing to make payments based on outcomes and pay back the investor who has put the money up front.
So when it comes to the CARDIO4Cities initiative, sorry to interrupt you, I just wanted to know, is there something there that would interest investors?
Absolutely. I think the fact that there is so much evidence is already extremely positive. And so the question is a bit what kind of model of the two can be followed, either providing financing to enterprises that play a role in the ecosystem around innovation, about data, diagnostic, or because through an upfront investment, you can actually save a lot of lives, but also a lot of economic benefits that could be accrued. So why not invest a lot of money today and then have it paid back over time when the outcomes are realized?
Well, I wish I was a multi-billionaire. I would definitely invest. I'm going to take questions from the floor in just a minute. I just want to give a last word to Álvaro, just to close the circle, as it were. Just give us a little flavour of, you were talking about CARDIO4Cities across the global impact, but drill down into Sao Paulo. Give us a little flavour about the transformational impact CARDIO4Cities has had in that city.
Well, the first impact is to have real data showing that we are doing the right thing. So we didn't have data as we got in the CARDIO4Cities Accelerator. We didn't have that data. As Thijs just said, we have digital technology there, but the way that the data was collected was not the ideal to have metrics that could reassure that we were doing the right thing. So that I would not say transformation, but beginning of transformation, because 10 million people, if I said that, so let's just assume that 50% of this population is adult population, so 5 million, and almost 50% of them, they have hypertension. So we are discussing 2.5 million hypertensive patients. So by having the data of a few thousand, it still is a long way to go, but at least we know how to do. So I'd like to see this transformation in the years to come.
You're on the
But
path.
the beginning was good.
On the path. Thank you very much. I'm going to, at this juncture, I've got loads of questions for these guys, but I'm going to give you the opportunity to ask some questions. Has anyone got any comments, any thoughts on CARDIO4Cities? Lady at the front here. Can I just check, is there a microphone that's going to come to you? Yes, there is. This lady in the lovely red dress, thank you.
Thank you so much. This was a wonderful learning. My name is Catherine Canary. I lead universal health coverage at an organization called AMREF. We implement in Africa with a presence in 35 countries. And so some of our work is around non-communicable diseases. And I love how this has been expounded. So my main question, when we look at universal health coverage, you're looking at quality of care and reduction of out-of-pocket expenditure. So for me, I'd like to perhaps understand the tackling of the health financing for this CARDIO4Cities. So who pays for the care? How did you advocate for that? I've seen policy reforms. Which policies and how did they affect this work? And then perhaps in terms of quality of care, was there a gap in the human resources for health? Because that's a big challenge that we have. So when we follow the patient journey, especially for NCDs, we lose them along many ways. So one is awareness. Then you go to the facility. The primary healthcare worker is not aware how to treat, how to diagnose, the equipment, and all that. So I'd like to just understand, the walkthrough.
So a couple of things to unpack there.
Sorry, many.
No, that's fine. We like lots of questions, and here's one. So first of all, let's talk about CARDIO4Cities as part of the universal health coverage in terms of funding. Who wants to take that question? Who pays for the care? I'm guessing the answer is it's all part of the multisectoral approach with local authorities. Rifat, do you want to talk a little bit about that?
Brazil does have universal health coverage, plus it has SUS, the Unified Health System. But in spite of that, the management of cardiovascular disease, hypertension, and diabetes is suboptimal. Although Brazil does outperform other Latin American countries, with the exception of Costa Rica, which is a consistent high performer in relation to managing these diseases. So universal health coverage is very important, because what we've learned from Brazil, in a study we published, is that when the family health program was introduced in Brazil, there was a rapid decline in what we call amenable mortality, which includes cardiovascular disease, because of interventions to prevent, but also interventions to treat. But that alone is not enough. So this is why when you ask the very important question of what other factors influence outcomes, we really want to have greater insights, because there are socioeconomic determinants, maybe factors that affect out-of-pocket expenditure that hinder access, maybe there are multimorbidity that also affects outcomes. But universal health coverage is critically important, but in and of itself, not enough.
So how the second part of her question was about how we have resources and staff in place, primary healthcare in place, how we actually follow through. So you have the data, you know what's needed. How do you get what's needed? My experts. Bill, please go.
I'll chime in from an AI perspective.
Yeah, don't look at me for the answers.
So
look at these guys.
I think technology is a lot of the solution, right? What these folks have described is the use of community health workers, which augments kind of the provider and physician workforce. But I think use of technology and AI to steer people to the people that they need to see and use those scarce resources much more efficiently than they are currently used, and address these collateral issues like social determinants at the same time, all can make the healthcare system much, much more efficient. I think I worry sometimes. I see people who have these long-term engagements like, oh, we're going to expand our physician workforce. You know, that's going to take 15 years, maybe 20, right? It's too late. We need to use technology to have healthcare become much more effective and efficient than it has been in the past, and to actually immediately, in the US, there's this adage that it takes 17 years to get a current practice into practice, right? Something has been proven, it takes 17 years to actually have it put into practice. With technology, that should happen virtually overnight. You know, something happens, it should be put into the guidelines, put into your phone, reaching out to to the patients to be able to help them control their own healthcare much more effectively and provide support for the provider workforce to be able to implement that immediately.
Right. Álvaro?
Just one more comment, because the technology is fundamental, but also from the research perspective, we should ask the right question and collect metrics that really is important for the patient, because sometimes we collect a lot of data and no question before that. So we need to think for diabetes, what is important, for obesity, for cholesterol, and for hypertension, and collect what is important to change people's life, and not collect all the information. So this is the only thing that we need to think before starting collecting information.
Right. So
May I come in on the...
We have data, we can know where to put scarce resources. We know exactly where to target them.
May I come in on the quality of
Please.
care? Okay, that was an important question that you raised. How do you look at the quality of care? There are 4 questions that we need to answer when we are addressing quality of care. Was the intervention beneficial? Was the intervention safe? Was the intervention resource optimizing, both in terms of human resource utilization and financial resources? And lastly, was the intervention satisfying to the patient, the family, the community, and to the care providers? And if the answer to all of these questions is yes, that means there is quality of care. And of course, you're going to use evidence-informed interventions. But ultimately, quality of care boils down to answering these 4 questions, and I think they've attempted to do that.
Thank you. Thijs?
Just relating for this and also quality of care. We are in a country that, as mentioned, we have universal coverage and a public health system. But at the same time, this program and this implementation, they're really key to the funding rules for primary care in Brazil. So now the municipalities should receive money from the public, the federal government for primary care. They need to meet 7 KPIs for primary care, like vaccination, maternal childhood, and chronic diseases, hypertension and diabetes. So if they meet those KPIs, they will receive their money. And this is pretty much related to quality of care, because in the beginning, they only needed to have the records in place. Now they need to achieve some quality standards. And one other thing that I would just like to mention is that some municipalities in Brazil, they're starting to establish something like a variable compensation for the health professional based on quality of care, so based on user satisfaction. There's one municipality that we invest in some programs there that they're already doing this and exactly focused on this type of KPI. So they're finding local ways to adapt and to approve things that can be on a policy level, but more local, and that can last longer.
Thank you. Thank you. Right, another question from the floor. Sorry, but
it's not a question. I just wanted to tell Anna and Philippe, making us stand has really worked on our hearts. So
I was going to say, if you're wondering why there are no chairs, it is because standing is very good for your health. We're trying to be proactive. Apparently, it does lower your blood pressure. I have it on good authority. Yes, gentleman there.
Thank you so much for the excellent panel discussion. I'm really excited to see such incredible progress in such a short period of time. My name is Antonio Spina, and I lead digital health at the World Economic Forum. My question is around, so I understand there's a huge opportunity in what seems to be secondary prevention. So sort of once someone already has hypertension, how do we detect it, get them into treatment, and so on? But I'm thinking about, a bit more upstream than that. There are going to be more structural determinants that are very difficult to address and may require bigger policy decisions, or ways that maybe we could use technology even further upstream very early on to identify risk factors, prevent more on the primary side. So my question was just around how much of that is currently being addressed in the CARDIO4Cities program, or is there a way to either use this as a platform for bigger policy discussions or maybe leverage technology? I know, for example, in Brazil, there's been a lot of progress made on nutritional labeling that could be relevant. And also, it's quite early stage and controversial, but for example, nutritional advice or exercise advice via generative AI, things along those lines. So I'd be very curious to understand.
That's a really interesting question. Do you have any comments about how it works at a higher level?
I'm happy to take it offline, but this program was really focusing on a primary level. it doesn't mean only primary prevention, of course, but I take the point about the need for that link. But we consider the data and the digital technology as a means to get to our end. It's not becoming the end on itself. So in countries where there was no digital technology in the beginning, we started with paper-based data. If it's needed, that's the way we do. So we adapt according to the local situation, and we move as good as it goes to where it has to be. But a very strong point. Thanks.
There is a question about, I think, how we leverage health innovations, particularly in low and middle income countries, to drive that health progress. Does anyone want to make a comment on that? Rifat again? Sorry to keep picking on you.
No, absolutely. But I think many low-income countries, low and middle-income countries have a distinct advantage in that they have young populations who are very tech-savvy. But also the penetration of mobile telephones in low and middle-income countries is actually very high. And very interesting, for example, you saw mobile phones for transactions for banking, M-Pesa. Kenya was ahead of most high-income countries. So there's a great opportunity to capitalize on the young population and the technology penetration, collect data. But very importantly, you asked about innovations. We tend to think of innovations in terms of technology, but we can also innovate in terms of the way we provide data or analysis back to the users. Very important to engage them or use incentives to engage them, or to use prompts or nudges or behavioral and psychological techniques to ensure better engagement and better adherence. But also use the same innovations to better optimize the use of available resources in terms of human resources, but also in terms of management of the care pathway. So there's so many innovation opportunities, but context matters. Very important. I heard the word adaptation, which is very encouraging in both the context of Dakar in Senegal, but also in Sao Paulo in Brazil. Local adaptation of innovations are really critically important for their adoption and scale up. So that means really understanding the context within which these innovations will be introduced.
And also making sure that those low-income settings don't get left behind when it comes to integrating this kind of health innovation into their health systems. Anyone want to add to that? Okay, cool. Next question. Gentleman at the front here. If you're at the back, I just want to say, really put your hands up because I'm quite short. So if you're at the back, please put your hand right up so I can see you.
Yeah, thank you very much. I'm Elvis Zikum from Yaoundé, Cameroon. I'm member of the World Health Federation Air Pollution and Climate Change Expert Group. It's really an interesting presentation. CARDIO4Cities is really a big word for me personally. My question will go directly to Senegal because I come from Africa and I have this perspective of if we start talking about like reflecting our work should reflect the reality on the field. I'm really impressed by what Senegal has done in terms of bringing the NCDs with the multisectoral approach. I wanted to understand something when we talk about the multisectoral approach in Senegal, for example, you piloted this. Was the multisectoral approach around risk factor oriented, or it was just about institutionalization? Because when we look on cardiovascular disease and risk factors, we will take, for example, tobacco use, air pollution, which is something that nobody really cares about. But I want to really understand if this multi-sector...
people care about
Yeah. Some people care. I'm sorry, but not really many people. But yeah, I'll still be on that. But which is really an issue. Is this multi-sectoral approach just bringing maybe Ministry of Health or Education or Transport, but just looking at the ministries, at themselves and the world as NCDs?
Other companies.
Or they are looking at risk factors to really bring an impact, which I really like the points that the Minister of State brought out, like really clarifying what we should be doing. We should diagnose, we should standardize implementation, and also what we should get to patient, and that's where youths are involved.
All right.
Thank you.
Well, let's put that question to Senebu. So this is a question about when you have a multi-sectoral approach to NCDs in Senegal, are you looking at other departments which deal with air pollution, things like that, and other companies, other organizations?
Oh, thank you. Let me talk in French. Merci beaucoup pour la question.
She'll need a microphone if she's... Okay.
OK. Pour la multisectorialité dans le cadre de la lutte contre les MNT au Sénégal, l'approche, on ne s'est pas limité uniquement au secteur de l'éducation. Donc, c'est tous les ministères qui étaient impliqués. On a travaillé avec le secteur de l'éducation en premier, mais par la suite, on a travaillé aussi avec le secteur du transport. Parce qu'on est en train de mettre en œuvre, il y a une initiative qui est en train d'être, un projet qu'on est en train de mettre en œuvre avec les bus rapides transfert. Donc là, le ministère des Transports s'est approché du ministère de la Santé pour ensemble étudier l'impact en rapport avec la pollution de l'air, qui est un des facteurs de risque de ces maladies non transmissibles. Vraiment pour mettre des actions. Donc, on va mettre en place ces bus pour faciliter un peu le transport de la population. Mais en conséquence, il faudrait aussi qu'on puisse mettre en place des actions pour réduire cette pollution de l'air qui peut vraiment entraîner d'autres maladies non transmissibles.
So maybe if I can...
Let her interpret that.
So
I heard Minister of Transport in there. That's all I heard.
The multisectorality approach in Senegal has very much involved the Ministry of Education, but also the Ministry of Transport to look at how to reorganize transport, roads, systems, and to look at also the question of air pollution as an important risk factor in Senegal.
Brilliant. Thank you.
Et en plus du ministère des Sports, on a aussi d'autres ministères. Par exemple, le ministère, en plus du ministère du Transport, on a le ministère des Sports, avec qui on veut vraiment relancer une activité qui se faisait il y a de cela plus de 10 ans, qui est des compétitions qu'on faisait depuis l'école élémentaire, le moyen secondaire, jusqu'à l'université, qu'on appelait USU, et qui est vraiment une stratégie vraiment pour promouvoir l'activité physique. Donc, pour vous dire qu'on ne se limite pas uniquement à 2 ou 3. Et il y a les partenaires aussi qui sont là, sur place, avec qui on travaille pour vraiment les amener à booster un peu. Donc, et à côté de ça, on a créé l'Alliance, une alliance de lutte contre les maladies non transmissibles, qui regroupe aussi tout ce qui est partenaire de lutte, les associations de malades, qui eux aussi vont contribuer dans contre ces maladies non transmissibles.
So two elements. So the Ministry of Sport is being solicited to re-engage and restart sports program for young children in school to promote sports education. And as well, all the partners are very much involved together with the Ministry of Health in developing an alliance on NCD that is multisectorial and that is really pushing for the fight against NCDs in Senegal.
Thank you. Thank you very much indeed, Senebu. Do we have any government representatives in the room who would like to comment on CARDIO4Cities? Yes, gentleman at the table there. Helga, thank you.
Thank you. Not a question, but a comment.
Yeah.
I would like to do. First, to congratulate all the panelists and have respect to our minister, our teacher, Professor Awa Marie Coll Seck. It is a big honor for us to participate in this meeting with her. And really, thanks to Novartis for this initiative. You see, Senegal delegation is very important for this meeting because the subject is very important for us. I think we have a lot of experience with Novartis since Better Heart, Better City, CARDIO4 Dakar. We have a lot of experience. We have a lot of good results, a lot of evidence we must share with other countries. But as you say, we must accelerate. I think we must do, and we can do more and better. That's why I say a very big thanks to this new project, CARDIO4Cities Accelerator. I say welcome to this new project. And we pledge to support these new projects in Senegal and we will do our best for its success. Thank you very much.
Great to hear. Thank you. Thank you. And we too want to see it accelerate and progress. Thank you very much. Any other comments or questions about CARDIO4Cities? Gentleman at the back there, thank you for raising your hands high. That's great. I saw it.
I'm glad you did. Thank you very much. And thank you to the speakers. I missed out on a big chunk. I was enjoying the public service on my way finding this place. And thank you, Anne, for inviting me once again. But my question is precisely about that. The public health system back home, I think, could do with a bit of improvement so that people have more confidence in using it. We have very many road traffic accidents. Our public transport, especially what we call the matatus, we would really want to use them more often. But the most common item on news really is the number of accidents that we have. So I'd just like to encourage the CARDIO4Cities to be a little wider. So not just the NCDs in the clinical sense, but also the road traffic accidents, which would really, just to come up with innovations to help that. Thank you.
It's an interesting question, actually. If we have success with CARDIO4Cities, what could we not expand it to? I mean, how far could it go?
That goes to NCD. The more we spread, the more difficult it is going to be to deliver impact. And as such, it's really critical that we are able to first focus on CARDIO4Cities and cardiovascular disease. Obviously, over time, this initiative being successful can be replicated and expanded, but let's first make it successful.
Thank you very much indeed, Philippe. Okay, another question for our panelists. Two at the same time. Okay. Gentleman in the suit and then the lady. Thank you very much.
Sorry,
ladies first. No,
thank you.
I
have a feeling that Senegal has spoken way too much, but I'm very pleased to see that. I'm working for PASS in Senegal, and we've been a partner to the Ministry of Health and IntraHealth on a previous opportunity. But just to say that Dr. Job is the Director of Diseases Control in Senegal. I have a question for all the panelists, and any of you can pick it up and respond. It looks like the diagnostic is very clear. All the ingredients of the recipe is there. We have everything to make something big with this initiative. I would like to know then what would be the thing that we need to do to make it this big success that we are expecting from such an initiative? What we need to stop doing, what we need to start doing, and what we need to continue doing. Thank you.
Ooh, big questions. Okay, who's going to take that? What are the main ingredients? So go ahead, Hassan. Thank you.
So I'll start with one. I was talking earlier about political will. Where we've seen similar initiatives really work at scale is when there is a national strategy and a national call to action. So I think it starts with a national and supranational approach to say, can we really tackle cardiovascular disease at scale in the same way we did for cancer or HIV. We see good examples. The Japanese government recently came out with a national cardiovascular strategy. Now within the European Union, there is a European strategy now for addressing cardiovascular health across the European Union, which gives a really good platform then for member states to take that on and use their sovereign responsibilities to tackle this. So it needs a real kind of political call to action.
Okay, political will. Go ahead.
No, maybe just from the investor perspective. I think obviously they need to see the opportunity to generate return, but also impact. I think what's interesting today is that more and more financial investors and development agencies, foundation work together. You know, they blend their capital, investment, and grants together to attract more private finance. So that's one. And the second is clearly the sense of urgency. So call for action.
Yes, thank you. From this side, yes, Rifat?
Yeah, I'd concur. One is very strong leadership all the way from the top with clear action and prioritization, making an investment case and urgent action. But what we've heard from the presentations is critical importance of engaging the users, engaging the individuals, because we are dealing with lifelong conditions. An individual with high blood pressure may have that for 50, 60 years. And they will not just wake up in the morning and say, Yeah, great. I'm going to go and have my blood pressure measured. So we need to really think and get new insights on engaging individuals, but also very important communities, critically important to develop these networks, peer networks to support each other and to scale up these innovations, which has been really great successes in Dakar and also in Sao Paulo.
Well, apart from a combination of political will and professional skill, I think we need to redefine PPPs. PPP is conventionally defined as a public-private partnership. If it is defined instead as a partnership for public purpose, then there can be multiple partners. You can have two government departments working with each other, health and transport maybe. You can have the government working with the private sector, with the NGOs. You can have two private sector entities working together. You can have two NGOs working together, ultimately with the idea of serving a public purpose together. You can have a government, private sector, and NGO partnership as well. So you can have multiple partnerships emerging as long as the public purpose is clearly delineated, the deliverables are clearly defined, and the accountability mechanisms are also sketched out.
But they have to be the right partnerships, right?
They have to be the right partnerships. Obviously dedicated to that public purpose, bringing bringing their own skills, but bringing in the synergy of partnerships. I mean, a synchrony of effort and a synergy of effect.
I just want to ask you, because Amani is in one of these PPPs with health authorities. What was the challenge of that? Did it all go swimmingly, or were there things to overcome?
We faced two challenges. The first one, I think it was more about data and data availability and how to work with it that I already mentioned. The second one that I would say is more about governance.
Right.
It's not easy until you understand how you should navigate in different places and require different strategies. And I think that in this project, we took some time to understand this and how we could give the state, the local authorities, the ownership of the program. This is the O for the cardio is one of the key factors of success. But it's not one size fits all. You need to really understand how you should adapt and the mechanisms that you should build to make the things
and the
last.
Goals have
because
to be
I think by the end of the day, we are interested in a policy that will last more than one legislation. So.
Yeah. Thank you. Good point. We've got time for a couple more. Yes, please go ahead.
Well, thank you. I'm not from Senegal, but I really appreciate all of the comments and the leadership coming from Senegal and the different case examples that were presented here. And congratulations to the Novartis Foundation and to everyone involved. I think it's very inspiring for all of us to really see these results. Coming from Portugal, at our primary healthcare level, we saw that just the simple fact that started measuring controlled hypertensive patients and diabetes patients in Portugal in our primary care settings led to a doubling of control. So as everyone has said, if you don't measure it, you can't fix it. But if you measure it, it almost fixes itself, right? But we actually then added a financial incentive for the healthcare teams, not just for doctors, but for the teams based on health outcomes. And that led to an additional adding of 10 to 20% on the results. So measuring is impactful. Creating financial incentives, as was mentioned, can even take you further. And this is a very important point because as soon as you start measuring and you have these results, you can get complacent. And especially in politics, I've been a fourth-term member of parliament, you can get to this point where you're better than all the other cities. That's what's going to happen in Brazil and everywhere. The city doing this is going to be better than all the rest, and that's enough for the mayor and for everybody to say we're the best. But you can go further. And so looking at where you can go and creating more incentive and not being complacent, I think, is a very important rule. The other is, why do we not collect more data? And I think we need to address this also from a political perspective. The fact is, people don't want to collect data because that makes them accountable. And if those that are actually in the power to collect the data, don't want to be as accountable, well, they won't do it. And so from a political strategy perspective, anyone advocating for this kind of change should use moments in which there is a switch in political leadership in a country, city, or region. Because that's the moment where you want to shame whoever was in power before and show that you can actually do more moving. I'm sorry I'm being a bit cynical, but it's a reality. And I think doing that would be extremely important. But Bill actually mentioned the role of AI and technology, and I fully agree. But we know also there's a trust issue now. A lot of people are distrustful. You come from Microsoft, and people, people think Bill Gates put chips in vaccines and things. So we are living in dangerous times. Wouldn't it be great if there were a neutral platform to working with WHO that could actually help accelerate AI, responsible AI in digital health? And actually, I started a position today as CEO of IDARE, which is a great coincidence, which is the International Digital Health and Artificial Intelligence Research Collaborative based here in Geneva, working with WHO. So there is room, because the power of AI, I believe, will be transformative. I fully agree. I just have one question. Out of all of the experiences in 3 different completely contexts, from what I understood, we talked about the successes here. What were the main challenges, the difficulties, and how did you overcome them? I'd love to hear about that. Thank you.
Thank you. Thank you very much indeed for your question. Well, what were the challenges? Melanie, do you want to talk about the challenges in data collection? And also maybe add to the point about the trust and the challenges in trying to collect data in the first place.
Absolutely, yes. So just starting out, each of the 3 sites were in very different places in terms of data collection. And it took a lot of management in terms of the monitoring and evaluation portion of the project, just to get everyone aligned, make sure that we're collecting the same metrics and in the same way, so that data can then be comparable. And I think that's what's going to be really interesting going forward, is keeping that momentum going. It's going to take some work and data capacity building in different locations. As was mentioned earlier, a lot of places are still collecting their data on paper. So there's a lot of movement. There's a lot of potential there, a lot of building that we need to do. And just thinking about the potential around data itself, AI, there's so much opportunity to pull together additional data points from the environment, thinking about social determinants of health, to the point earlier about pollution, traffic, all of these other pieces of data that we can pull in with the health data to really identify some gaps around those social determinants. What are those challenges, and how do we fix them? It may not be through the clinic, to your point. It's through the government. It's through the local administration. So it's just taking the time, which that's also a challenge, to your point about collecting the data. It takes a lot of time and diligence to make sure you have good data and that is trustworthy and can be actually used to combat some of those assumptions that we all deal with in maintaining and improving health in our worlds.
Thank you. Thanks very much.
I would say, can you hear me? Yeah. I would say 2 factors, and this is based on our own experience in 5 years in Brazil. To be honest, they are challenging. Some factors, they are easily fixable, but those tools is not easy, and we didn't have time to expose everything. First of all, is to align the strategy with the existing strategy of the government. This is, I would say, the most difficult. And not because they are not doing the right thing. They are doing. But we'd like to improve what they are doing. So it's not easy. At least in Brazil, it took a few years, in 5 years, maybe 2, just in terms of convincing conversation, effective talking. And the second one is to establish an efficient coalition. This is a wonderful word, but it's tough to establish coalition. It's nice to put in the slide. But if I was in the position to suggest you, okay, try to concentrate your efforts in the tougher ones, coalition and alignment government.
Thank you. Thank you, Álvaro. I know there are lots of questions in the room, but we are under a little bit of a time crunch, so I'm going to bring this part of it to an end. However, I would say to you, these guys are all going to be around, and they will welcome any other questions. And if you want to ask about the challenges, Anne is here and offering herself up to talk to you. Thank you so much for your insightful questions, and thank you very much indeed to our panelists. I am going to hand the floor now over to Anne and to Philippe to formally launch the CARDIO4Cities Accelerator. There's going to be a short video before that, and I would like you please to just give a last round of applause to our speakers.
The CARDIO4Cities Accelerator now. Right. So here we go. We built this accelerator as a separate organization, and it will be hosted for the first year or two under the umbrella of our best partners, IntraHealth International. And we will build this accelerator together to become a neutral broker between all the governments who are asking us to replicate the CARDIO4Cities approach, the private sector players who want to engage and commit to this important fight against cardiovascular disease, the implementing partners, the academics, the experts, the civil society partners, all together, investors, funders, I was almost forgetting them, all together bringing it under one umbrella. So this is a real pleasure tonight to launch the CARDIO4Cities Accelerator with Philippe from IntraHealth International. Philippe?
Thank you. Thank you. And first of all, well, thank you, Novartis Foundation, for the vote of confidence. This is a huge responsibility. This is extremely exciting. We will aim to be actually that broker that can help facilitate the interaction between cities, governments, private sectors, and funders, and most importantly, patients. Let's never forget those patients. We owe that to them. We don't owe that to ourselves. We owe that to those patients. They've been waiting for too long. It is now time for us to change that tide. And really, as you were saying, let's all become activists for that CARDIO4City challenge. This is now the CARDIO4City Accelerator. Let's accelerate it all together. Thank you.
Thank you. And then I have a very nice surprise for us tonight, because we will call upon all of you to commit and engage with us in the fight against cardiovascular disease. But we have two first pledges tonight, and everybody else welcome afterwards. But the first pledge will be done by my colleague Philippe from Novartis, who is going to make the first pledge for our CARDIO4Cities Accelerator.
Great, thank you, Anne. So partnership starts with making a commitment. So today we're going to be making an important pledge, which is a start of really scaling up cardio cities across many more countries and many more cities. So I'm delighted to say that Novartis will be actually pledging a secondment, a full-time, fully dedicated person to cardio cities, someone who will work with IntraHealth and with the foundation to make sure we can bring this to many, many more cities around the world.
Thank you, Hasib. Fantastic. Thank you so much, Hasib. This is our first pledge, and our second pledge comes from Thais.
So after this 5 years of intense work and implementation in Sao Paulo, and also one replication within the city, now we are pledging to replicate to up to 3 new municipalities in Brazil in the next year.
Woo! The 3 first replications of CARDIO4Cities in Brazil, because our mission with the CARDIO4Cities Accelerator is to replicate CARDIO4Cities in 30 cities within 3 years. Who wants to help us? Any other pledges? It doesn't have to be now. You can always come to us after. But with that, I just wanted to take a moment to close this fantastic discussion with you all. And I was so happy to hear all the success factors for CARDIO4Cities coming out of this discussion with the great panelists we had tonight. First and foremost, it is all about local ownership, political will. Without that, it doesn't work. The first success factor. The second success factor, it has to be a coalition, a collaboration, I would say, between sectors. We need to work with many more different non-traditional health players. Otherwise, we would never have identified people at cardiovascular risk. If we looked only at the health centers, we were missing all the men in Brazil. We had to go find the men. Remember, Álvaro? We had to go find the men where they were, at the exit of the football stadia or in the subway stations. So the third success factor of CARDIO4Cities was absolutely clear and loud in all of the responses. If you don't measure what you do, you don't know what you're fixing. But if you do measure, I like your point, Ricardo, if you do measure, it fixes itself. You see, it's almost true. But all of these factors were so important. And the last one, I will never forget this anymore, Srinath. The most difficult challenge we had was aligning everybody behind the same goal. It is very difficult. And it takes a lot of time in the beginning. So that alignment behind the public purpose, that's the partnership we have to build. So thank you, everyone. This is where we're going to with our CARDIO4Cities Accelerator. So please join us, and we'll come back maybe in a year to tell you how many cities are doing it, okay? Now you're all welcome, warmly welcome to a reception in the back of at the exit, in fact. Please.
Wow, my goodness, not so good to see you.